Good morning and welcome to the second day. We hope you had a good night's sleep because today is filled with complex interventional endoscopy procedures, starting with the case of a 69-year-old male who presented for weight loss, 17 kilograms in 1 month, upper abdominal pain. From the personal medical history, you find out that the patient was diagnosed with pancreatic tumor in the onset process, invading the celiac trunk and superior mesenteric artery in November 2018. An US plus FNA was performed from a lymph node but was negative for malignancy. He performed the choledochoduodenal anastomosis in November 2018. He is known with permanent cardiostimulation for arrhythmia in 2018 under treatment with aspirin, which was stopped 7 days prior to the procedure, cardiac ischemic disease, COBP, and hypertension under medical treatment. The blood workup shows mild pancytopenia, and the CT showed the pancreatic tumor in the onset process and cephalic process, invading the celiac trunk and superior mesenteric artery, and aerobilia due to the choledochoduodenal anastomosis, with no longer liver metastasis. The procedure will be on US plus FNA and elastography, plus contrast enhanced ultrasound. The second case is a case of an 85-year-old male who is known with right hemicolectomy with iliotransverse anastomosis for synchronic colonic adenocarcinoma in June 2018 with atrial fibrillation under treatment with anticoagulant but was stopped 3 days prior to the procedure, and low molecular weight heparin was started but was stopped 24 hours prior to the intervention, colonic diverticulosis, and prostate adenoma. The blood workup showed mild cholestasis, and the CT of abdomen and pelvis showed no metastasis. The colonoscopy showed a colonic polyp, Paris 1S Cudo 3L, of 15 over 10 millimeters at 45 centimeters, and the biopsy showed localized, moderately differentiated adenocarcinoma, and the procedure will be an endoscopic mucosal resection versus endoscopic submucosal dissection. The third case is the case of a 58-year-old female who presented for jaundice, upper abdominal pain, and fever. From the personal medical history, we find out that she had a giant cholelithiasis in March 2018, for which an ERCP and a biliary plastic stent was put in of 10 French over 10 centimeters. Intraductal breast papilloma excised in April 2019, cholecystectomy in 2002. A hepatic hepatic cyst removed surgically in 1979, and pulmonary tuberculosis in 1977. The blood workup showed the mild normochromic normocytic anemia with hepatocytolysis and the cholestasis with a total bilirubin of 3.2. But in March, when the stent was put in, she had a total bilirubin of 27. The ERCP, which was performed in March 2019, showed the dilatation of the CBP up to 20 millimeters with 3 images of gallstones of 20 over 18 millimeters, 12 over 12, and 10 over 10 millimeters in the middle part of the CBD, with dilatation of the intrahepatic bile ducts, and the procedure will be ERCP plus stone extraction.
Morning.
Morning. Good morning. Can you hear us? It's okay. Okay, thank you very much. So I'm together with Radu Tutuian. You saw him, and we have a large team here together with the anesthesiologist. So the patient is intubated, and we started already the examination. I don't know if you have the endoscopic ultrasound image on screen. Okay. So we started the examination with a linear scope. So we have a combination of Olympus. We have an Olympus linear scope, and then coupled with an Aloca F75 ultrasound system. The anatomy of the patient is a little bit changed because he had surgery previously. So he has a choledochoduodenal anastomosis. So the position is not perfect. The endoscope is a bit twisted, so we struggled a bit until we reached the head of the pancreas. But you can see the tumor now, so Radu is helping me with a pointer. The tumor is about 3.5 centimeters. You see it's hypoechoic, and then it invades the common bile duct. So we are in the duodenal bulb towards the, I think, the second duodenum. We couldn't reach the second duodenum, but anyway, the position now is pretty stable. And the patient already had an USFNA previously, which was inconclusive. So we will try to repeat the USFNA. That's the plan. We'll try to use an acquire needle. We'll do the FNA with biopsy. We'll use a histological needle. And before that, we wanted to use also contrast and elastography to get a bit more information.
We also wanted to show you sort of for the junior people in the room.
Yes? Yes. Good morning, Thierry. The confluence, the confluence is most probably it's invaded, and I'll show you at the end. There is a lymph node near the celiac trunk as well, which was punctured, and it was inconclusive. So the confluence is a bit. I'll try if I reduce a bit the image, then you probably see the vessels, but we struggled a bit with the position, so we will do the contrast, the elastography, then the FNA, and then I'll try to look at the vessels for the staging.
The other interesting thing is because here this colorectal diversion to the intestine, the common bile duct up here is fairly normal size, so it's only 6.5 millimeters, so it's not enlarged, but this is due to the fact that this has been derived proximally. Because you can appreciate here how the tumor sort of occludes here the distal part of the choledochus, and you see sort of normally you would have this sort of all the way followed through the papilla, but you see that the process here, and it's this very inhomogeneous, unsharply delimitated structure. In the pancreatic head, we measured it. It's as Adrian was saying, this is about 2.6 by 2.8 centimeters, and that's the whole size of the tumor. I'm gonna save this image now. Oh, sorry. Can you hear me? Or should I come near?
Maybe I'll give you my microphone.
Close to Adrian. It looks very cozy.
Or on the other side, if you want. Okay.
So what Adrian was probably. Shall we go for the puncture first and then do the measurement?
We can do some elastography if you want quickly, and then you'll see immediately if we change the region of interest now, and if I play a bit with the up and down wheel, so the position is a bit twisted, but you see that that there is a mixed appearance. So on the whole, if we measure that with strain histograms or strain ratio, I guess it will be hard. So that's how elastography works. It's not perfect here because the endoscope is twisted, so probably it's not a perfect perpendicular position. And then we can also try to inject contrast. So if we can mix one vial of Sonoview, that will help us a bit to see also the splenomesentery confluent, because it's pretty far down below, and with the Doppler we get a lot of artifacts. But we'll change the settings to contrast.
Presets to contrast.
Okay. So and then looks a little bit changed, maybe like this. We had a lot of problems with the contrast, and now we have a lot of noise here, so I don't see very well where it is. Maybe this one here.
The tumor is over here.
I guess.
That's what it is, and what we're going to focus now, sort of, we have a fairly low mechanical index of 0.14, so that should be good to see.
We can try. We will try. We struggled a bit with the settings because the F75 is an ultrasound system which is a bit old.
Okay.
So the settings are not perfect, but we'll try like this and see what happens. Otherwise, we'll do the FNA and see what happens.
Da, vă rog, da.
Trebuie doar întrerupt aici un pic și... Ok.
This is kind of the ideal setting for doing contrast ultrasonography, because you have already the IV line in place. You can actually easily do I think it's important sort of to have not have the bubbles destroyed through the start of the IV line. So and it's important to be able to flush quite rapidly. The timer. Yeah. We need to find the timer.
Go back.
No, that's sorry. That's not.
It's on my phone.
Okay, here we go. We have the counter here. Yep.
Samo čekamo na to da ići.
Och det är klart för att bina inte. En sekund. Nästa då. Okej, perfekt. Jag tror att jag kan kontrollera. So if I can just quickly show. Mask. Okay. So for those of you, this is the contrast for the ultrasound, and it's really, there's no actually contrast, there are only air bubbles which are trapped inside the liquid. So there's no problem if you have any patients with renal insufficiency and all that, you don't need to worry about that even if you do contrast ultrasound imaging. So what we're going to do now, I'm going to flush whole or half a vial? The whole.
I'll try to start the counter.
This one, okay. Oh, yeah, so what they actually also nicely did is you don't want to do it in the IV line, you want to have a dedicated line to do that. So we're gonna... Yeah. Okay, got it. So, sorry. Scusa, scusa. Okay, so we're gonna start flushing the contrast. So the contrast is in, sorry. And now I'm gonna flush this quickly.
Yeah, I'll start at the counter, so now it's 10 seconds.
Okay.
I'm not sure if it works very well, but we'll see. The grayscale image is not perfect here, so whenever the grayscale image is not perfect, then the contrast is not perfect. So it's okay, I'll wait a bit more. Yeah, if you save this image, then the whole video will get started and then you're going to be in progress, that will save it all the time, so try not to store it at the moment. Mai aveți un flacon, să-i mai dăm un flacon? Da? Și aici nu văd nimic. Nu văd nici microbulă, poate pe aici un pic. Da.
So it looks like to be a poorly perfused lesion. You don't see any...
And I'm not sure about the settings because I only see I see some micro bubbles here, and whenever there is a lot of noise and whenever the grayscale image is not perfect, then it's not going to work. So that settings, now Radu is adapting a bit the settings, but anyway, the grayscale image is not perfect, so it doesn't work as I would have expected.
You can see some bubbles now coming up here. This is
it's not much
in the vein, but it's not much, and you would normally want it to have it over here. This is where you're looking for the...
And also in the SMV, we are almost at 2 minutes now, so it should have been in the both the arterial and also the venous system, so I don't see it very well. But we'll switch back for the FNA and then we'll try again with the settings because something is not working as expected. So we'll see how it works. We'll switch back to the okay.
Sorry. Ah, okay. Yes. Yeah. Thank you, Madrina. That makes it much nicer to see.
It's better.
So we expect now the needle to come out here somewhere, and you can actually plan your puncture. So you want to make sure that you don't have any vessels up in this area, which looks actually good. There's a really tiny vascular signature here. You can actually see them better now after the contrast enhancing.
Yeah, we should have seen the maybe it's here. Here it's probably the
SMV.
Yeah, the SMV. which is most probably invaded, but I'll try here since I'm a bit more stable. Merge ceva, nu merge la contrasta, nu știu ce. Vedem, încercăm aici. So whenever we do the fine needle aspiration, it's always helpful whenever the lesion is on the uncinate process and in the pancreatic head, then the endoscope is twisted. So I will need some help. Îmi puteți ține și mie un pic să nu iasă, da? Because whenever we push the needle in, the endoscope tries to get out. So then we might lose the position sometimes. So then it's really helpful. Somebody should keep the endoscope in place. So we have our hands free. So we are using a histological needle basically because it's a rescue procedure. So the first US FNA was not okay. So that the needle should be fixed on the biopsy channel, and then we will adapt a bit. So I'll try. Aici dacă
în sens contraorar, foarte
Ok.
ușor. Spre dumneavoastră și împingeți puțin înăuntru.
Ca să încerc eu să scot un pic gata. So the first thing is that we should have the needle, the plastic sheet out. It's not an easy position. Now maybe it's a bit better. So maybe now we got a bit in towards the second duodenum. So I'll try it from here. We released the second knob, and then we'll get out the stylet a bit, and then we'll try it from here. Okay. Trebuie să fie ok de aici. Că încercăm așa.
Yeah, perfect.
Sau așa.
So he has about a range of 2 centimeters to go by.
Trebuie să fie. Okay, so maybe now I guess I should be in. Now you can see that the needle tip is probably somewhere there where Radu is showing. Is not the perfect position, but we'll try it from here. Cam așa.
You can also appreciate when Adrian is pushing the needle in, how the whole tissue moves
Now
around, and that happens
you
with
are
the
seeing
heart.
it better.
Yeah.
Okay. We are doing the FNA with suction, so we still prefer suction, although it's a histological needle. So now if you torque the scope a bit, then you see better the needle. So now you can appreciate the needle. So it's somewhere in the middle of the mass. It's very hard, so you can actually feel and then palpate somehow the lesion. So now you see better the needle tip, which is inside the mass. And you probably see now better the SMV, so what Thierry was mentioning. So you see the portal vein and the confluence there, also with Doppler. But again, the settings are not perfect, so of course we would always have preferred a newer system, but this one is okay. At least for FNA we can do our job properly. And the advantage of the acquired needle is that you can obtain a lot of tissue even in 1 or 2 passes. We don't do more than 2 passes because you get a lot of tissue, so you will see. And the idea is to move the needle inside a tumor, because when I push, you see that the whole tumor goes a bit far away. But I think that's okay, so we can try and see if we got something. There are various ways of expelling the material. So we will try with the stylet and see if we get something, and I'll stay here. Sometimes you see the needle tract, so you are seeing also the needle tract a bit on the screen. So after the FNA, so you actually see the needle tract. Cred că nu m-am formol. So what we usually do with histological samples, we put them into formalin directly, and if we have a bit of material, then we can try to smear it. So we put it on the slides as well. so you need to do imprinting, so you push very hard on the slides, and then we also do a few slides. But that's because our cytopathologists are still requesting slides as well. Otherwise, the material is usually enough for histology. And we usually do 2 passes, especially in a patient which is, had a previous USFNA which was negative. So we'll try to show you the material if we got something. Otherwise, we'll try again. You have pick, so
Yeah, there is.
I'm not sure that there is something. Sometimes it's bloody. I'm not sure how to put it. Maybe here. I don't know if you can see it. You have to look inside. But there is some material, not much, and probably it's a bit bloody. But we got some pieces of tissue as well. But let's see.
Adrian, with regards to the number of passages, there are some discussions as to how many one should be doing. Do you gauge this on the size of your lesion to decide whether you want to do 2, 4?
Yeah, it depends what you want to do with the material. So if we do the only FNA with the conventional needle, we do at least 3, maybe even 4. We had some molecular studies, so we collect the 4th sample for molecular studies. With the acquired needle, then it's a bit more easier, and we stop at 2.
Yep.
So now the endoscope is a bit more relaxed, so I'll try again. Let's see. I think I have it there. Okay. So again, we'll try again. Retract a bit the stylet, and then I'll try again. Now you see better the needle, and you are seeing it inside. I cannot get to the to one margin, but I think I'm in if I go here. Okay, o întrebare, dar nu aud nimic din.
Mircea, we don't hear that very well. Can someone tell us what the question was? That
Yeah,
Yes,
you can see
yeah.
it moving with the needle. So the idea is to move the needle tip inside the tumor. So you now see the needle tip, and the idea is to push the needle inside the tumor. So now we've also placed suction. I'm not sure if that helps the suction. Sometimes the material is too bloody, but here maybe it's helpful. I don't know. The studies are not very convincing, so even if you do with suction or without suction, I think the results are more or less the same in pancreatic tumors. For lymph nodes, sometimes it's better without suction. Trebuie să avem ceva.
Yeah, this part of the tumor seems to be quite hard, and that's why you see how Adrian is really fighting to get it across this. But he's definitely in the tumor. You can see the edges here of the tumor, so it's not that he's just pushing the duodenal wall. He's actually inside the lesion and trying to get some. Now, again, you would like to do fanning, but that's sometimes a wishful thing, because if you're in a very hard position, you don't want to lose your position by attempting to fan. So.
Okay. So now you see better what Thierry was mentioning. So we moved from the common bile duct, and now you see the portal vein. The Doppler is not perfect, because if I increase the gain, then we also have some, you see some small tinkling artifacts, and some aliasing. But anyway, you see the tumor, and it's completely invading the splenomesenteric confluence. So the splenomesenteric confluence, you cannot see it, you cannot appreciate it, how it goes. So at one, you see the portal vein very nicely, and then at one point it disappears into the mass. So you don't see very well the splenomesenteric confluence. So I guess the tumor is not resectable. There is also a lymph node on the celiac trunk, which should be far away. So we will try to puncture that on the way back, because if it's positive, then it's metastatic. So again, he will probably need chemotherapy. I don't think it's resectable here. I don't know what is your opinion, but it's a 3 centimeter tumor, maybe even 3.5, and I don't think it's
Adrian,
resectable.
what do you think about this tissue here?
Maybe a little. There are some there, and it's not blood. It's you see, it's a bit whitish.
Yeah,
So
if you
I
can
think
focus
it's,
sort of that's you can focus on the bottom of the vial. You can see some of these really small, very small white strings inside, and this is what you actually want to get. You don't want to get big, chunky, bloody strains because the pathologist will have a hard time telling what it is. But this one looks pretty good.
okay.
Yeah.
So basically, even if the pieces are very small, it's sometimes even half a millimeter or 0.2 millimeters. So even if the pieces are very small, they can still do microhistology and they can still do immunohistochemistry. And then if you use molecular markers, then you get more information. And there are more and more studies showing, for example, that KRAS, if you do KRAS, then you further increase the accuracy to almost 96-98%. So you can get diagnosis in almost 100% of cases, even if the position is very difficult. But I'll
Would you like to try another third passage?
No, I'll try to withdraw and look at the celiac trunk again. So I'll withdraw. Now we are in the stomach, so we'll withdraw a bit the endoscope. Mulțumesc frumos. We'll try to locate. There was a lesion nearby the celiac trunk, so at around 50 centimeters. Whenever the scope is at 50 centimeters, then we expect. So I guess the celiac trunk. Let me see where the aorta is. Now you see
That's
one
the
here.
lymph node, yeah.
So there are a lot of lymph nodes here. So you see one here. So we can target that because it's nearby the celiac trunk. So I'm with the endoscope at exactly 50 centimeters from the incisors. So I think this lesion, if it's positive, then it also changes the management. And then a lot of patients also have mediastinal lymph nodes. About 10% of the pancreatic cancer patients have mediastinal lymph nodes. And if they are, they should be punctured as well. Încercăm tot cu asta sau dacă aveți, putem tot cu asta acasă. Da. Avem un obișnuit, un expect, că ăsta e curbat și the idea, if you have a lot of needles, then it's perfect. So the idea is not to puncture with the same needle in this exact order. So the idea, if you use the same needle, then you should go for the metastatic lesions first in the liver or on the celiac trunk or in the adrenal, and then go towards lymph nodes and then puncture the primary tumor. If you have multiple needles, then the perfect setup is to puncture each lesion with a different needle. So in order not to to move the malignant cells from one place to another. So we change the needle, and you can see that this is straight now, and after one passage, usually it gets bent, especially in the pancreas. So it's really difficult to do the second or the third passage with a needle which has been used. So again, this is a new needle. It's an unusual conventional needle, and it should be enough to target this lesion. It's not a big one. I don't know how large it is.
About it was 10 by
10
millimeters, so it's kind of it fulfills a bit.
Yeah. It should be okay. So now with the endoscope in the stomach, you see I can move the lesion again. Now it's a bit on the side, and if I move a bit the up down wheel, you see that I'm going with the lesion in the center of the image. So now it's a better position. For example, here again it should be fixed, and you will see when we get the needle. Now you see the needle shit out. And now if I move with the elevator, you see that the needle sheet. I'll try to show it here with the cursor if we have.
You can probably get a cursor marker.
You want the cursor?
Da.
Here.
I guess it.
Hold on, just 1 second. Just
First you can use the cursor there.
can I get you?
Get rid of the other one. Okay.
So you can
that's
use
perfect.
you can use this sort of this marking sort of.
Okay, so you see here, I'll try to get it, and you'll see my plastic sheet is here somewhere, and you can move it. Actually, I can move it with the elevator, so now you're seeing it better. So that's the plastic sheet, so we know we are out of the biopsy channel. We are fixing it here. We open the second knob on the FNA needle. We draw a bit the stylet, just now you see the needle. So, and you see when I'm pushing, it's really easy. So this was an easy lesion to puncture. So if you have the up wheel and then a bit the elevator, then it's easy to target. And now we can also try to get it there. We draw the stylet and we'll place some suction. So this one is really soft in comparison with the tumor mass. This one is really soft, but sometimes it's more difficult to puncture from the stomach. Yes?
The lesion is on the left side of the spring, the lesion itself.
This one, sorry, or I'll.
What can I see on the left side?
You mean this one? You mean, yeah.
Yeah, there's another one there. So it's two of them. So I'm not sure if it's another lymph node or this one looks like a lymph node. So it's a bit round. And there's another one here. So we can actually target both of them if I play with the up-down wheel. And now you see the celiac trunk and also the probably the SMA a bit below. So, but you can target both of them playing a bit with the up-down wheel. So now I'm keeping the up wheel a bit. So the big wheel, I'm keeping it a bit up. So then you have a good contact with the gastric wall. You see, if I twist it more, then I get this lesion. If I release it and go a bit down, then I can go to the other lesion. That's the region where the celiac plexus neuralizes. It's done. So I'm not sure if it's only a lymph node or it's also some celiac plexus ganglia, because the first one looks like a lymph node. The second one, I'm not sure.
Yeah, I think.
Mulțumesc frumos. So this one, because it's a lymph node, I expect it will be a bit bloody, but you can see very nicely here is the aorta and the celiac trunk here. So this one, I'm pretty sure it's a lymph node. This one here might be the celiac ganglia, and also these ones here. So they are usually hypoechoic. So if we would have planned the celiac plexus neurolysis, that's the area where you, now Radu was increasing the image, so that's the area that you want to target. Okay. So I don't know if
Can we have another passage? In one?
we got something or. We don't have much, so we'll do another pass. Usually for lymph nodes, 2 passes is enough because they're a bit more bloody. We
There are
have some
small fragments.
Yeah, there are
They're
some
really very
pieces.
small fragments, but yeah, let's try to get.
Mai încercăm o dată. I think this was the lesion that was punctured initially, so it was negative. There were some bowel loops interposed so that the primary tumor couldn't be targeted, but anyway, we'll try again. So again, we'll go with the plastic sheet of the needle, and then we fixed it on the biopsy channel. You have to release the elevator all the time, so we fixed it here. And now if I play a bit with the first knob here, you can actually see, then Radu is helping, is pushing the scope a bit. So now you can see that I can play a bit with the elevator and change the angle. Dispărut cursorul, nu mai știu unde este. Ăsta? Okay. So you see here the plastic sheet, and I can actually change the angle now if I'm moving a bit. So now it's better like this. It's not always a good idea to have the elevator completely down because the puncture will be a bit more difficult, but here it's easy. So now you see for the second pass, it doesn't go through the stomach wall. So then I have to put a bit more. Se întâmplă la al doilea pasaj, nu mai vrea să treacă prin peretele stomacului. Ia să vedem. So I have to go with a more forceful thrust. So now we are inside the lymph node. Okay. We'll take the stylet out and then do the again we'll place some suction.
What we are trying at my place to do is sort of, I usually try to teach the assistant sort of how to assist with the puncture, because that for the operator you can see that it's very difficult. You have only two hands, and it helps you sort of a little bit fixate. I'm moving this a little bit now, so if I push the scope in, the image will go to the right. If I pull out a little bit, the image will go to the left.
So now you see that we can do fanning, what Radu was mentioning, so we can target different regions of the same lymph node. Maybe also go a bit, that's okay, maybe a bit down here. Of course you have to avoid the vascular structures, but anyway it's a fine needle, so even if you go through an artery nothing happens. It's a bit more dangerous to puncture veins, but anyway everybody tries to avoid the vascular structures. Okay, so we'll stop the suction and then we'll see if we got more here. Okay, so I don't know if you have more questions. We'll try also to look at the left liver lobe with a better system. Usually you can see the complete. Now you see the hepatic veins, and then we'll see the now we have the aorta, and then if I switch, that's the kidney here. And then the adrenal on the way back, we have to locate the adrenal. That's the spleen.
Yeah.
And then the adrenal should be somewhere here, I guess. That's the kidney. I don't see that left adrenal. It should be. There are some calcifications on the aorta. Should be somewhere here. Spleen. Maybe somewhere there. I don't know. Now it's a bit better, so it looks better with the second pass. And then I'll move. You need to follow the same stations, and I'll move a bit in the mediastinum. So still following the aorta. You see the aorta here. So now I'm at 40 centimeters. So I'll move slowly in the mediastinum, and then torque the scope on all sides, and we'll see if we have some lymph nodes also in the mediastinum. Okay, so we'll getting out on the aorta. That's where we are at 30 centimeters now. So that's the where the aorta is turning towards the left side, but I don't see any lymph nodes here in the mediastinum. So I think we can conclude that's the tracheal rings. So basically, this is if I go on the trachea, that's the subcarinal space, but there are no lymph nodes here, and that's the
left atrium.
Yeah, the left atrium.
The pulmonary trunk. And then if you zoom out a little bit, then you can actually even see the mitral valve and the aortic valve.
Yeah.
So you cannot charge for that since you're not a cardiologist, but
exactly.
You can actually.
This is
the tricuspidal pulmonary valve, and then if you torque a little bit, then you will kind of see this is the left atrium. You can see the left auriculum, and then the mitral valve, and then you can see here down here the aortic. This is the aorta. If you push in a little bit,
like this,
and then sort of see like this one here. This will be sort of the aortic. You can appreciate this cuspidal aortic valve here.
with some calcifications.
Yeah.
So you can also look very nicely, and there are some small lymph nodes there, but this
This one is here.
look a
Sort of,
bit.
yeah,
exactly.
these are lymph nodes which are here. Sort of. Let me zoom out a little bit. So if you measure this one, and this is really Adrian really holding the scope that you can make the measurements
I'll try.
live. Otherwise, you will always have to. So this is 1.2
I
centimeters.
think it's two of them. One,
Sorry, yeah,
it's,
agree,
it's
yep.
two of them, or maybe. So these are really small. So usually
Yeah.
you find lymph nodes in the aortopulmonary window in all smoking patients. So these are really small. So I wouldn't puncture them. They're a bit more oval, and they don't have worrisome features. So they are not round. They are not hypoechoic.
So this would be one lymph
yeah,
node.
that's one actually.
It's here 0.8, and then the second one is probably here.
It's even
So
smaller. It's
even
5
smaller.
millimeters. Okay. So you can actually see if you do a systematic examination, you see all the stations, and you can actually find very small structures. But I think that's what we could do for this patient.
Okay, thank you, Professor.
Thank you very
Thank
much.
you very much.
We switch to room number 2, Professor Constantinescu. You are live.
Good morning for the audience. This will be a basic case of colonoscopy plus polypectomy. But first I want to introduce my team. Dr. Catalin Sfarti from Iași.
Hello.
Dr. Omar, doctor in Bucharest, and our colleague, Dr. Marilena Epure, which is our anesthesiologist for today. He supports us for every case. And our nurses, Florin, Gabriela, and the others. First, I want to show how to organize the lab for a normal colonoscopy and polypectomy. It's better to check from the first our instruments. We use here Olympus system, is the latest version, is Xera 3 series, and you hear me? This is the instrument, the colonoscope CF HQ 119L, long, L means long, which is a very good instrument. I want to show the devices. They are prepared from the first step. It's better to check exactly what you have to use. For example, we have a needle for injection. It's 5 millimeter. The needle is, the length is 2,300 millimeters. Is fit for using in long colonoscopes. Snares, different size of snares, but it's better to check the compatibility between diameter of devices and the instrument. For example, if you want to do a polypectomy, you have to prepare your hemostasis instruments. For example, coag grasper, which is very popular everywhere. This device is 2,300 millimeters long, and the diameter is 3.2. So it's not possible to use it in normal gastroscope, but for 3.7 channel colonoscope is possible to use it. Then different injection, methylene blue, saline, China ink, and we prepared the the place where we have to put the used instrument. So this is the place we organize for device. So we have to start doing colonoscopy. Is there any questions from the audience? First, we check again the devices. Today we use the Olympus Cauter ESG 100. We check the flushing pump, which is of paramount importance in case of hemorrhage, and the CO2 insufflation, which is also very important in case of perforation or in different situation. CO2 is the best option instead of normal air insufflation. So we have to start doing colonoscopy.
So your patient is laying on the back because he's intubated, I think.
Yeah. The patient, as you know, the patient is 85-year-old. He had the previous hemicolectomy because colonic adenocarcinoma, and some weeks before, doctors he was diagnosed with a small polyp but ulcerated. We'll see. Histopathologic result is an adenocarcinoma, a small adenocarcinoma, and we have to check this lesion again, and in order to see what to do for this patient. He's an 85-year-old with permanent atrial fibrillation and anticoagulants, and he has many comorbidities, especially cardiac comorbidities. The patient is intubated for the moment. Is very stable, hemodynamic stable, and now we introduce the instrument and
what have you done with the anticoagulants in the thinking of maybe to take out the polyp?
Yes, anticoagulants has been stopped for several days. Now he's for I don't know 8 days, 7 days. He's able to receive a polypectomy, no problem. He has no anticoagulants and antiaggregants for the moment. This is the sigmoid part. The endoscope is very good, as you can see. The lesion will be at 40 centimeters from the anal margin.
The preparation of the colon doesn't seem very good.
Yeah. But this is the reason Dr. Sfarti says that the preparation is not very good, but this is the reason we have the flushing pump, which is a very useful thing. The lesion was described at 40 centimeters.
He has a resection of the sigmoid.
Yes, yes. Not the sigmoid, the left, the right colon, and the right part of transverse colon. He has a right hemicolectomy want to improve a little bit the stiffness of the instrument in order to obtain an easier advance of the, check a little bit the abdomen. Push a little bit, stop. First step, I want to see the entire remnant column, and then we try to find the lesion. When we withdraw the instrument. Probably reach the end part of remnant column. Somewhere here we have to see.
Yeah, it's the blind loop.
Yes, we have to see the anastomosis, ilio-transversal ilio-colonic anastomosis. Look, the anastomosis, which looks absolutely normal. The diameter is quite normal. There are no problem here. Now I try to flash in order to observe small lesions in the colon. We sometimes use antifoamic agents, but not in this case, but it's useful because it's very efficient against foaming. You know, we have to withdraw in a couple of minutes the instrument in order to see every fold, every corner of the column, but we previously done another colonoscopy which don't show any lesion except the polyp we expect to find in a few moments. as I already said, is a basic colonoscopy. There are some mandatory steps. Like careful withdrawal.
There is a small diverticula, I think.
Yeah.
Yeah.
There are small diverticula, but
With this preparation, it takes surely more than 6 minutes to redraw the
Yes.
colonoscope, and you need a lot of movement back and forth to see everything.
yes. I want to put into the flushing pump some anti-foaming agents. We'll see the difference. We stop a little bit the procedure.
We are using a full-sand solution for the
Yes, yes, yes. Okay, it's enough. It's for elephants. Good. Seems to work. Look, it's different.
Yeah.
It's quite different. Probably.
Do you also recommend to the patients to take 1 day before this anti-foaming
Usually
product?
not. We don't recommend, but usually we use anti-foaming agents
During the
in,
procedure.
Yes, during the procedure. Okay. Is a little bit better, in my opinion. The report is a small polypoid lesion, but small, so it's possible to be found with difficulty. Usually it's better to mark from the beginning the lesion in order to be found easily, but is not in this case, was not possible in this case. So we have to check.
Yeah, the marking is extremely important in situations
Yes.
like this, because
Yes.
otherwise you have to look a lot of time for the small lesion.
Now the colon is clean. Let's check again. The report is at 40 centimeters. The previous report. These situations happen sometimes for small lesions. Doctors send to us small lesions, which are very difficult to be found if they are not marked definitely with a China inch or a clips or a no. A ce distanță e? What's the distance?
Gabriel,
Yes?
how large was the lesion? You know?
Under 1 centimeter. A little bit with ulceration in surface, but a small lesion. Is not my patient, so for me for this patient is the first colonoscopy, but is a documented lesion with okay, but because foaming, we have to check carefully again.
Sometimes I receive patients for EMR and I spend several minutes or more to find the lesion. Sometimes I would like to my colleague who have a book with me
Yeah.
I asked the resident also to look all together to find the lesion.
Yes.
And 40 centimeters on the sigmoid, it's very tricky.
Yeah, yeah.
Sometimes it's,
Sure.
in some case, I use, for example, a gastroscope because you have a bed
Yes.
handy, and I use a gastroscope with a cap to see the animal.
Yeah.
And sometimes I use immunocarbon also to find the lesion. Sometimes very tricky. It's
Yes.
more tricky to find the lesion than the result.
Yes. But in this case, the coloscopy is a little bit difficult because he has some adhesions and modified abdominal anatomy because previous right hemicolectomy. And of course, if we don't find the lesion, we have to switch to normal endoscopy.
To the other room until you find the lesion.
So we are again in the transverse colon. The situation is better here. We see more than before. Okay, I hope we'll see the lesion.
Right
Look,
there.
look.
Yeah.
I've
This is the
cited
lesion.
the lesion. It's a small one, as you can see. Is that
Are we still live?
yes? Look, the lesion. This is the reason we didn't see it from the beginning because it's very small. It's under 1 centimeter.
Yeah, the depressed center is suspicious.
Yes,
Yeah.
yes.
Yeah.
He's a small adenocarcinoma. He's an adenocarcinoma. The endoscope is not a very good position. Is not in short root. Is a little bit angulated, and I want to mark a little bit the. So I prefer to start with China ink injection first.
But it could be interesting. Is it a near focus endoscope?
Yes, but
You can use the near
no.
focus to analyze the.
Yes, but
It's
it
a very interesting test.
yes, but it doesn't for near focus, despite the fact that it's the latest version, but it's not prepared for near focus. I'm sorry.
And NBI?
Yes, NBI is.
This just because it's a very interesting lesion to analyze. You see in the middle.
Yeah, the pattern
Yes,
is not preserved.
The relief disappear
yes,
because the pattern disappear in the middle.
Yeah.
yeah.
Yes, and
Also the vessels.
maybe,
Yeah.
of course, there is probably a cyclical invasion, and maybe a tip, so it's difficult to.
Dr. Hey, what do you mean? What will be the next step here? You can come here. Okay, come here. You can hear Dr. Yohei?
This one.
No.
But I think it's important. It's important to determine the nice classification, but more of a genetic classification to know if it is 2B or 3. I think I will be happy to know if it is 2B, 2A no, but 2B or 3.
Yes.
2B means you can perform endoscopic resection, 3 you have to go to surgery.
Let's mark them. Let's mark.
So,
Hi, can you hear me?
yes, you can comment on the lesion.
Okay, the size is not so big, but this polyp shows the redness and the center part shows some depression. So by white light imaging, we have to consider its SM invasion, and if we can use the NBI magnification. In Japan nowadays we are using the JNet classification, so it must be helpful. But today we can't use the magnification, so in this case it's better to discuss by using the nice classification. And when you change the NBI mode, in this case we should check the depression part, and it looks still surface is not absent, but shows irregularity, and also the vessel is not regular, so it's difficult to say it's nice 3, but it's absolutely not the nice type 2. So like this case, I think magnification is very useful. In my impression, if we can use the magnification, I think it's like JNet type 2B, so we have to suspect the SM invasion for this case.
Yes, so 2B means,
Yeah.
2B means it's maybe a superficial submucosal invasion.
Yeah.
So it means that the risk of lymph node is very limited. So it's an indication, at least for endoscopic treatment, at least to attempt.
Yeah, in this case, it is worth rejecting endoscopically and as a total biopsy. Of course, we should put tattoo after rejecting the polyp, but if we judge type 2B, have risk of SM deep invasion, but some part it's maybe superficial SM invasion, so it is worth rejecting endoscopically. But of course, after injection, it shows non-lifting. We should give up, but
Yes.
it is worth. How do you think?
Now, then, as we decided to perform a resection, endoscopic resection,
Yeah, if lifting is good.
If lifting is good, yes. But first, I have to mark this area because it's possible to lose the position. Yeah.
There is a nodule. There is a nodule. Yes, that's it. Yes.
Mevrouw Verre. Is dat? Okay. Yeah. It's okay. Another mark.
Yes.
Okay.
Maybe it's helpful. Yeah.
Up.
Because of a small nodule in the
Yes.
middle.
Will be enough.
Agree too.
Will be enough. Now I try to put into the position in a better position the colonoscope and start injection. Injected? No. Okay. More. Okay. Open it. open? No. I start doing injection from the beyond. More. Wait. No, stop. No. Okay, wait. No. It's not a lifting sign. What do you mean?
Yeah, I don't think it.
Okay, we
So
can.
I think it's a pad free. Huh?
Yes,
Yeah.
it's normal lifting sign. Okay. Good. Inject. No. Inject, 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 inject.
Yeah, the lifting is beside the lesion.
Yes.
It's not so nice.
Yeah.
Stop.
No.
At the maximum, it could be an indication of ESD because
Yes.
you can manage the sclerosis.
Yes.
But EMA will be very difficult. Huh?
Yeah.
Yes.
I agree with you. And the depression part, we can see the nodule at the center part. So it's also the sign of SM invasion. But of course, it's difficult to say this is SM deep invasive or shallow one. But the non-lifting sign is also one of the signs for SM deep invasive one. So if we can't get the good lifting, it may be.
But you could lift at the end, but perform ESD. I think in photometry for the patient, it's a very interesting case to discuss. And the first operator, the first endoscopist has to be congratulated to find
Yeah.
such lesion.
Very hard to see lesion. No, it was a good screening colonoscopy.
Was biopsy taken previously? Or?
Yes.
Yeah, adenocarcinoma.
Yes. Yes. We had biopsies with adenocarcinoma.
It makes more complicated. I'm not sure that the center nodule come from the biopsy or not. I don't know. That's the problem.
I don't find two. I don't think two. I don't think this is due to the biopsy. This is the problem. The fact that it does not lift is due to the lesion itself.
Do you think an ESD will work or no?
Mm,
Or a surgery is more suited?
Yeah, if we want to remove it endoscopically, I think with snare it's slipping, so it must be difficult to detect en bloc. So ESD is one option to get the total pathological assessment. But in this case, we have to attach the distal cap and we have to set again.
And using maybe a gastroscope?
But
Because you are not too high.
It's on the transverse colon,
it's
I think.
It's too far from the null margin.
Splenic
Will be
angle.
difficult.
No
Will
splenic
be
angle
difficult.
of the-
It's possible, but probably difficult.
But nevertheless, Gabriel, it is a very interesting case. Unfortunately.
Yes, yes, yes. Small lesion, small adeno.
And to demonstrate the lesion for the discussion. But why not to attempt ESD? Huh?
What do you mean? You wanted to try an attempt for ESD?
if you need me, I will challenge.
Okay, why not?
I think the patient is 85 years old.
Yeah, yeah.
So the patient is quite old.
Yes, yes. He's not fit for surgery. is not fit for surgery.
We'll switch to ESD.
So, okay, so
And laparosurgery is not possible here because he has previous open interventions. It's not possible
Okay.
to do laparoscopic.
another option, but full thickness resection will be also an excellent option. I know it's
Yes, and
quite
possible.
expensive, but it could be a great option.
You have to try.
But
So remove.
Yeah, remove it.
We have dual mic prepared here.
Okay.
So Yohei says to switch to normal gastroscope.
Yeah. Therapeutic gastroscope, please prepare. At first, I will try by using the therapeutic gastroscope, and if it doesn't reach, I have to change the colonoscope. But at first, I want to try by therapeutic gastroscope.
Overfall. You have to check the therapeutic gastroscope.
Yeah.
Check first,
yeah,
please.
Yeah.
If is the instrument you desire.
It will take time to change the scope and check setting. So go to
Yeah.
other.
Yeah. We can switch to another room and we'll be back in few couple of minutes.
Okay,
Can
so
you
who
hear
are
us?
we with? We have our audience. So I think you've heard the story. So right now we're set up for basically a spyglass cholangioscopy. And right now we're using the Olympus, the new scope with the disposable cap for sterility. It's the first time I'm using this. We're just going now into the duodenal cap. And there is our stent. Okay, so it looks like a small papilla, but there's been a previous sphincterotomy. So the plan, of course, is to take the stent. Let's take the stent, rat tooth. Yep. So we'll remove the stent. We might need a small snare. This is a small rat tooth. I'm not sure it will hold on. We have a great view of why stents get clogged. There's something inside the stent. We don't usually get such a nice view.
Would you consider it pulling out the channel scope?
Well, it's 10 French, so it
Yeah.
should go through, but I'm not sure about this rat tooth. We'll
Okay.
see if it's going to hold. Otherwise, we could just come out of the patient. It's quicker to come out of the patient, I think, rather than to... Okay, let's just grab this thing. Now, okay, grab. No, you rat tooth or snare. Close, close, close. You have it tight. For let's start, let's fluoro. Okay, less magnification. There's too much magnification on the fluoro. So I think we can, I don't want to ruin the scope. I'm going to come right out. It's easier. And we lock on. We'll just watch fluoroscopically. You have the fluoroscopic image. There we go. It's gone, open. Now we have the chance to show you the new head. Dragish, close. So you can see this, maybe you can see this is, we don't have this yet in the United States, but I know it's available here. Yes. And so now it's a disposable head. And Marcel tells me he has it and loves it.
I love it, yes.
There we go. Testimony, so that's good. So we go back down.
That is single use, completely single use. You cannot reuse.
Uh-huh. Okay, so now I think to start, let's take a occlusion balloon with a wire.
Okay.
So, but a big one, a 15 to 20. 15 to 20, we know the duct is big. And if you look at the fluoroscopy already, without this scope, you can see we have pneumobilia. We have a massive duct. We can see this on the plain film, which we know from the previous cholangiography. So we know we're dealing with a massive duct. So we'll use a big balloon to go in. Now let's see, where are we here? We just clean the lens here if we can. There we go. Getting better now. Okay. So she has a short duodenal cap. It's unusual, maybe previous peptic ulcer disease. It's kind of a little bit of an unusual cap. And we're sort of turning the big wheel down to go into the duodenum. It's a little bit different. If we look at our endoscopic image, too much magnification. Do we have X-ray person here? Who can reduce?
Only if we, yeah.
Reduce, but I think it's already too magnified. Because I think it's good for the audience to see the shape of the scope.
Yeah.
Let's see. Too much? Go back. Less magnification. Yeah. Okay.
It's better.
That's good. That's no problem. So we can see the scope is unusual shape for ERCP, but let's just see if we get a better position. There we go. We'll take the balloon and the wire now. So we have to have a strategy. We discussed our strategy beforehand. And one thing I want to show, Dragos, is you see here, for our nurses and everybody in the audience, you never use rubber without using a lubricant. Rubber means lubricant. So always we put lubricant here. And the important thing for every device, so you have the tactile feeling. So we're going to go down.
So, Professor, you usually go straight with the balloon, not with the sphincterotome, yeah?
Straight with the balloon if previous sphincterotomy.
Yes, of course.
Because
if
the
previous sphincterotomy, yes.
But ordinarily my cannulation technique is with wire. So if there's a previous sphincterotomy, you're looking at the papilla, you say, where do I cannulate? You always cannulate where the normal mucosa joins the papillary mucosa. So we are not going to go here. We're going to go right up here, underneath, right in there, and that's where we're going to find it. So always with previous sphincterotomy, that's where you're going to get your orifice for the bile duct. So stop. First of all, let's get the X-ray in position to see intrahepatically. We're not. I can move it maybe. Let's see here.
Yes, I will help you.
Yeah. There we go. So, what's the principle of injection? The principle is don't inject underneath the stone, because then you push the stone up into the liver. So we know the stone, the big stone below. So the principle is we're going to put the balloon above the stone, wire back a little bit, stop, wire back.
You have the shadow of the stone already?
Oh yeah, we see the stone,
yes.
but I'm not going to, I still want some a cholangiogram. But I agree we could start just with a SPY, it's easy, of course. We have the pneumocholangiogram, but I want to make a point about injection, that's all.
Of course.
Yeah.
Yes,
Wire back a little bit more. Back. There we go. So now we can inject a little bit of contrast. And sometimes what I do, if I'm looking at, let's say, PSC, or I'm worried about a stricture, I pull the wire back so it's not in the way. So we take the wire and, we get it out of the way. And then when we inject, we won't inject too much just to show you. And now we inject from above coming down. We can blow up, we can blow up the balloon to 15 or 18 here. Stop. Now we have we see the stone. Okay, we see the stone, a massive stone, very large stone below. So I think, what we don't, because we're going to do cholangioscopy, of course, as Marcel pointed out, we don't want a lot of contrast. But this is the way we inject to look for stones. We have a large stone there. And now what we will do is come down, because the plan is to dilate, to do a sphincteroplasty, because we know we're going to have very large fragments. So now we have to focus on the bottom end of the duct, because what is the determinant of the size of the balloon? The determinant is always the diameter of the bottom end of the bile duct. We talked about worry about perforation. You cannot look at the bile duct in the common hepatic, the middle. You're going to have a duct which is 20 millimeters. What determines determination is what is at the level of the papilla. And the duct naturally narrows when you go through the pancreas. There's the pancreatic groove, the duct is in the pancreas, this is the problem. So we're going to come down, just a sec, we'll come right down here. We can blow up the balloon. Blow up the balloon, that's good. There we have the balloon. Contrast please here. No, stop, okay, that's good. So we're going to focus. I'm pushing my scope out of the way. I'm not looking at the endoscopic, I'm focusing on fluoro. I want to know my diameters, what we're working with. So the scope is 12.4 millimeters in the body. And now, so the duct at this point is probably about 10 millimeters, maybe 11. So if you go to a 20 millimeter balloon and this duct and dilate, you're in trouble. Inject. But we'll inject more. Okay, we'll come back more. Okay, now we can't pull the balloon through. It's 15 millimeters, it's too tight. So I asked my assistant, let out 1 cc, remove 1 cc, and the balloon will come down a little bit, and now we'll try to pull through. Now I'm going to look also at my endoscopic image here, and we're going to pull down and see how it comes through. Okay, now the other thing, let's put the wire back up the duct before we pull out. Just advance the wire, keep going, stop. Okay, a little more. I like a loop in the wire. If I can get it, I'll take a loop, but I don't want to go through the capsule. Stop, we're at the capsule. You can get a capsular leak, be careful. So we bring the wire back a little bit. Okay, there we go. So now let's get the dilating balloon. My feeling here, and I'm curious to hear what our moderators think, but my feeling, I'm going to go with maybe a 12 millimeter balloon. Maybe I'll go to 13. Thierry, what do you think, man? Okay, we'll come back. Yes. Yes. Okay. We'll exchange.
So we have 12 to 15 one. Yeah?
12 to 15.
Yeah.
I can't hear Thierry. Sorry, we cannot hear the question. What's the question? Again? Yes.
Question concerns the gallbladder. Because the patient has
What did you say?
The gallbladder. The gallbladder.
Oh, the gallbladder's out.
Yes, it's
previous
out.
cholecystectomy is out, yes. I think it was 2002.
Yeah.
So now we're going to do the dilation. We'll have a 12 to 15 CRE balloon. Now this is a long balloon. The problem with the CRE wire-guided balloon, it's 5.5 centimeters long. So again, we're going to get more dilation than we really want. But I think what we'll do is we just have to watch and keep a lot of the balloon outside the duct. So we'll go back. We have the gun ready to inflate. It's all ready, the gun. We have it? Okay, because we have a lot of work. No, the inflation gun.
The manometer.
This is the dilation balloon,
Yeah,
right?
yeah.
Okay.
Scary.
Okay. Good. So let's come back with the wire. Let me just check the wire again. Yeah, it's too high. Wire back. Back. Okay. Okay. Good. Okay. Keep the wire there. When I go forward, just bring the wire back a little.
Okay.
I know. Okay. There we go. So we're in the duct. Okay, I think this is enough. We have enough balloon. So we'll start to inflate. Let's go to 3 atmospheres, which will take us usually to about 12 roughly.
Just a second.
So we see the radiopaque marker at the top of the balloon and the bottom. You see our balloon is straddling the duct. We have the endoscopic image.
How do you manage the situation when there could be some stones between the balloon and the bile duct?
That is something that people always ask. Can you perforate a bile duct if you blow up a balloon against a stone?
Yeah.
I have to knock on wood. I don't know where the wood is. I never had this happen in 35,000 ERCPs. It has been reported.
Yeah.
It has been reported maybe 2 or 3 times. Let's inject the balloon, please. We're waiting for the gun. So the strategy, the plan. We're going to dilate up, 12 to 15 roughly. I'm going to go 12, I'll see if there's much. Then we'll take the spyglass because I think there is some interest to see the spyglass in the duct. The issue is ordinarily we would do electrohydraulic lithotripsy for very large stones like this. We don't have that, so the plan will be to try the mechanical lithotripter. If we can't get around the entire stone, maybe we get on part of the stone. So, but we would like to have a look before we do the lithotripsy. When we have the lithotripsy, then we have a problem with a lot of debris. Okay, we're almost ready.
Yes.
So right after this, we're going to put the spyglass up. We'll have it ready to go, right? Okay.
So 3 atmospheres.
Yeah. Okay. Let's go ahead. We'll go to 3 atmospheres, okay. I'm going to push away a little bit, make sure it's out of the scope. Okay, we'll have a look as we go. Okay. Tell me when you're at 3 atmospheres.
And the risk here for acute
It's now.
So the risk is of acute pancreatitis. Now we'll leave this for at least 30 seconds. Are you at 12 now? 3 atmospheres? So
Let's
the
go
trick-
to 3 and then I'll block it.
No, you can leave it unblocked, but just to make sure.
It doesn't hold the pressure, you know.
No, the reason it doesn't hold the pressure, the question here is, it's not holding the pressure. If you look at your fluoroscopy, well, we don't see it now. There was a waist in the balloon.
Yes.
As the balloon expands, of course, the pressure goes down. So when you want to maintain 12
So you need
millimeters,
to
you
raise
must
the pressure
keep
now.
injecting to maintain 3 atmospheres of pressure. We always expect the waist, as it opens up, for the pressure to go down. So we don't lock in. We watch the pressure, maintain the pressure. Okay. I think, you know, the major concern with pancreatitis, you mentioned that. There were big differences in the American and European experiences and the Japanese experience. The Japanese have a principle of preserving function and preserving the sphincter. And very early on in the ERCP world, the Japanese never liked to do sphincterotomy. It was anathema, so they always wanted to dilate with the balloon. And they had very good experience, actually, with little pancreatitis. But if you looked at the population in Japan, mean age was about 75, older population. They didn't get the pancreatitis that we had in the United States. Case Halbrechts did a randomized controlled trial years ago of balloon sphincteroplasty in a native papilla versus sphincterotomy. In a native papilla, then there was a much higher risk of pancreatitis in the West, but the average age was 55, not 75. And the other thing was, in the United States, the randomized controlled trial was stopped because there were 2 deaths with balloon sphincteroplasty without sphincterotomy. And those deaths were in patients, young patients in their 40s, who had so-called sphincter of Oddi dysfunction or a variant of that. So sphincteroplasty is not a benign thing to do. But on the other hand, you have the right demographic, the right population, and now, if you have a sphincterotomy before, the pancreatitis rate is much less. Okay, now we can let the balloon down. I did enough talking. Okay, we'll come out now, I think, and have a look. But I would say that there's no question that, as Thierry said in his talk this morning, I think that the experiences from Mumbai and from Amit Medeo, who popularized large balloon dilation, have really had an impact on our ability to remove stones more efficiently. Now we'll take the spyglass. So we have the DS here. Okay, so I'm going to ask George or Marcel, hold the scope here, and I'll ask Draguš to show the spy. Okay, so a couple of things you want to check before. Of course, we have to have the light on. We could turn our light. Okay, so we have a light. Okay, we have that. We have a 3-way stopcock here. And we put our devices through here, but we have ancillary irrigation. And what we do in our unit is we have the same accessory channel is your suction channel. So what we do is we hook up suction to the channel. Suction goes here, and then this becomes our suction line. So what happens is, when we want suction, this is open, there's no suction, and we're talking about suction of the spine, not the big scope. When you want spine suction, we put our finger here, and automatically we get our suction. So we control suction with our finger here. Of course, the accessories will go through here. There's an O-ring, so we can close down the O-ring to prevent leakage. So that's one thing. The other thing we have to be sure, there are 2 channels, 0.75 millimeters for irrigation. You must have good irrigation. So we always make sure that we have good irrigation before we start. And the third thing that people have trouble with sometimes, if you could hold this, is to put the spy on the scope. Because they always feel that this band, Draguš is showing you this, I don't know. Can you see, guys? I think you can see. Okay, so basically, so the problem is it's going to end up here. But don't put it on here. Hold it up here. Yeah, hold it. Put it on down here. Down here, there's no problem. Even a weak guy like me can make this fit. And then all you do, boom, 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 and you have it where you want it. Don't struggle. Struggling is for the strong. Anyway, so we're ready to go. The last thing is you want to make the tip of the spy like the tip of a catheter. So we take the spy and we bend it. Okay, we have it bent. I lock it in to start with. Now it looks like a sphincterotome, a normal device that's supposed to go over a elevator. So we put it in the accessory channel like this. And what did I always say? A little dab will do you. Always. There we go. So now let's look. We'll have to give the audience an image of the spy. Let's see. We're wrapped around. Let me take it out because let's get this, pull that through. Thanks. We're just tangled up here a little bit. Okay. So now you could say the other thing is do you always have to balloon dilate before spy? Not always, but I would say make the mistake of ballooning more than you think you should. Because more often than not, when you don't balloon, it's harder to put the spy in. So those are the rules of the game. So now we're here. The next step is we're going to bend the tip of the spy to look upwards. We don't know which way it is, so I'm going to move it around. I've got to push out a little bit more. I'm going to bend it up. So now it's taking the axis of the bile duct. We preform it to take the axis. Now, can I push this in? Yes, I could push this in, but I don't push it in. I take the big wheel of the scope and I face plant. So you go in with the scope and you face plant, because that's the way you get your entry point. If we fluoro, we can see we're in the duct. So you face plant to get the spy into the duct, and now we are going to advance just a little bit. It has the natural curve. You can see fluoroscopically it has the curve. We're going to go up, and now when I'm up high enough and I'm stable, I release the lock on the spy, so now it will form a more natural position within the duct, and I'm not even looking now, I'm going up the duct. So the spy is ideal in a duct of 1 centimeter or less. The problem with the spy in a duct of 2 centimeters, it doesn't have the field of view, it doesn't have the illumination. So we may not get the beautiful views we see with DS in smaller ducts. In larger ducts, we don't see that quite as often. So now I'm going to pay attention to my spy image. I'm going to have a look. I'm going to look for the lumen. There we go. We're in the lumen, irrigating, and we can see very nicely the intrahepatic. I have to say that the DS, the digital spy, is a huge improvement on the old system. But one thing we can see in this lady is that the ducts look very normal intrahepatically. We have a little debris up here, but that's not what we're worried about. We're worried what's further down. And you notice I'm irrigating a lot. What does that mean for the patient? That means the risk of aspiration. When we do SPY, we preferentially intubate the patients to prevent aspiration. You can end up with a leader sitting in the stomach. Okay, now we're looking. Let's look at the fluoro to see where we are. Okay, we're high, we're up in the right hepatic duct system. So we're going to come down to look at the stone. And as we come down, we're going to irrigate. We have a beautiful view. Of course, we can see changes from the stent sometimes, hyperplastic reactivity. And the one thing you see is that look of oil. That's your contrast. That's we did this to ourselves, but we'll come back. And we're getting beautiful views. We're trying to maintain the lumen. That's the right. This is the left over here. We don't have to go up the left, but very dilated. I certainly wondered in this woman if she doesn't have Caroli's disease. She has grossly dilated intrahepatic ducts, more than you would see with just obstruction. You don't get to this size with 2 weeks of a bilirubin of 10 or 12. This size bile duct has been there for a long time. Why is that important? Because of the risk of cancer. So we're doing cholangioscopy. We often biopsy to look for dysplasia in a duct of this size. Okay, let's come down. Our mission today is the stone. So we'll come down to see what's happened to the stone. This is a little debris, nothing big. And now we'll try to come back underneath the stone, and we're looking, okay.
You mentioned the Caroli disease.
Yeah.
Would you expect a certain pattern of the bile ducts in the Caroli
Well,
disease
Caroli
in
is-
cholangioscopy?
Cholangioscopy and Caroli just dilation, unless
Okay.
you have dysplastic change. So you
Yes.
could have low-grade dysplasia, you could have papillomatous change, but now there's our stone. If we had a EHL probe, of course, we would just touch it gently on the stone, we would break it up. So I just wanted to show you those aspects of SPY, but now really what we have to do is get the stone out. So we're going to see what we can do with mechanical lithotripsy. Now the SPY is almost out. You never know exactly the position of your SPY. If you see pathology, you must document it with an X-ray. You take an X-ray to show exactly where the SPY is, where you see the pathology, so that you will remember if you take a bite or a biopsy, you know exactly which part of the duct was abnormal. So that's what we do when we do cholangioscopy. Those are the basics of cholangioscopy. Okay, so now we're going to come out. We're still irrigating here, cleaning out, coming back. And okay, we're almost out. So the next step, now I'm going to go back to contrast. So just give me the balloon. Even though we have, let's just take this, we'll take the SPY off now. We don't need this. There we go. And I think, so the plan here, I think, is we discussed before, we will see if it's possible to catch this with mechanical lithotripsy. So let's look at the lithotripter to show the audience. So we have the Olympus lithotripter.
The lithotripter.
So we use, it's a little bit of an older system from Olympus, but it's the basic three-layer system. 3 layers. What are the 3 layers? I'll show you. One is the wire and the basket. The other one is the plastic catheter to allow you to move it up and down. And the third, of course, is the metallic sheath, so you can break the stone on the sheath. So we'll show you how this works. That's good, yeah. So here we are here. Dragush, can you come close? I think you're close. So I'll try to show everything here. So this is the basket, it goes forward like this. This is the largest basket we have. I think it's about 25 millimeters. It does come 35 as well. Maybe this might be big enough to get the stone. Below the basket is a plastic catheter here, and that gives you mobility in the duct. So some lithotripsy devices have a metal sheath right to the level of the basket. The problem with the metal sheath, it doesn't give you as much maneuverability. The triple layer system, you have a lot of maneuverability. So when we capture the stone, so let's capture a stone. Okay, we'll pull on the basket back. Okay, oh well, anyway, it doesn't matter. When you capture the stone, the next step, hold this here like this, just like there. Turn this to the audience like this. Okay. You can see, Dragush, you show them this. So you can see there are little notches. This indicates when the metal sheath, which is here, this is the metal sheath, as it goes forward, it's going forward to, you'll see here, it goes up to the level of the basket. Pull back with this. So now we have the metallic sheath to the level of the stone, and then we turn the wheel and we crack the stone. But in order to reduce the movement of the sheath, we lock into one of these little notches. It could be any one. It doesn't take a lot. It's just a little screw and you're locked in. So this does not change relationship to the basket. So let's see if it works. That's in theory the principle. And we'll pull the basket in. We'll pull the sheath back. We'll lock it in there. And you can inject contrast, but this is a small one. Contrast doesn't go in very well. It goes through the scope. So let's put the balloon in some contrast. I think it'll be better for the audience and for us to see. So we'll start just to demonstrate the stone first. The good thing is the stent has been in a couple of weeks. Maybe the stone will be smaller. I don't know. Okay. So we're going to now give everyone a good view of what we're up against, stone-wise. So we're going to go in, and this is a 15 to 20? Yes. Okay, good, perfect.
18.
15, 18, that's excellent, thank you. Okay. I have to say my assistant is extremely good. We didn't even discuss anything beforehand, And intuitively, he knows exactly what to do. So thank you for all your help. So now we'll inject contrast. When you have a balloon up the duct, don't blow the balloon up first. Always inject contrast first because you want to know that you're not stuck in a branch duct. So now it almost looks like we have a lot of debris here. So we can advance the wire. Let's get rid of all the debris first. So we'll advance the wire. Keep going, we'll go around the stone. Yeah, that's great. I love a loop. See, why do we love loops? Because loops don't go through capsules. It'll loop up into the duct, but it won't go through, and it helps you in the pancreas also. So now we're below the stone. More contrast, please. So we're a little bit below the stone. It's blocking up there. So we'll try to clean out the debris below. So we'll blow up the balloon. Go to 15. Okay, now it's going to be too big. Well, we'll see what we can clean out from the bottom. So at this point, I'm going to focus on my endoscopic image. And we're going to come down here, see what we can get to come out. And then we have a little bit of junk you see coming out. The smaller bits and pieces may come out.
Can you explain a bit the movement?
So the movement is go to a longer scope. So you go below the duct. You do that by pushing this. Let's do the fluoro. So if let's show you this. So when we want to maintain the balloon in the axis of the duct. So when we push the scope this way. So I'm pushing in to maintain the axis of the duct as the balloon comes through. And then when we're down low, the balloon is too big here, so we have to let 1 cc out. Hopefully it won't deflate entirely. Let just 1 cc is out. Okay, now we're going to continue to pull back and see if we can get, now when I'm pulling the scope to the papilla. Now to push the scope away, I take the scope in my hand and I push it away. Okay, there we go. And the balloon comes through. What do we get? We got, some little bits of debris. Or maybe more than bits. More than bits. But I think there's more than this. Okay, so now we let the balloon down. It's down. Okay. So let's go back and see what we have. You can see this is all sort of stuck together with mucus and whatnot. Okay, now try to come back to a shorter scope. Now let's just have another look and see what we have. Hopefully we get rid of all of the junk. Okay, we pull back shorter. That stone's in my way, but anyway, we'll get it out of try to get that stone to go down. There we go. Let's just get it. The problem is gravity wins over me. The stone is going to sit there until Newton changes the law. Okay, so now let's look and see where we are. Maybe the stone is, I see the stone is there, big stone there. So let us inject some contrast again. We can see the stone, blow up the balloon.
There's some more debris.
Yeah, more debris, yeah, you're right. We'll blow up the balloon again. Oh, just let's see where I am. Am I up high enough? Oh, the balloon's blowing up. Balloon down. We have to go a little higher. Advance the wire. We'll go above the stone with the wire. Okay, we're going to inflate the balloon beside the big stone. Inflate the balloon. Okay, it's sort of pushing on the stone a bit. Are you inflated now? I can't tell. There we go. It's very big. Huh? She okay? Okay, let the balloon down again. I'm going to maybe see if I can go back up. Balloon down. Okay, now just can you inflate it a little bit less? Go inflate. Inflate. Okay, hold it there. I'll try to get that one stone beside. I don't know if I can get it. No, it's not coming. Okay, let's see if we pull anything else. So I think we'll go, because we don't want to spend too much time on this case, I'm going to go with the mechanical lithotripter. We'll just pull out here, see if anything else comes out. Yeah, we get, no, I don't know. Let's see, that's the other stone. We'll get lower down. Now we'll push. There we go. Okay, let the balloon down. So let's go with the mechanical lithotripter to show how that works. So here we go. So now, with a little bit of lubricant. Now, I'm going to have to, yeah. So before we start, we have to be sure that we're locked. The screw, Dragos, The screw is closed here, and that locks the sheath away from the plastic inner layer. We'll hold that. And the other thing to be careful is not to touch this wheel. This will hold the wire of the basket on the handle. If you accidentally unscrew, of course, we lose the wire. But okay, okay, okay. Where are we? Let's get it. I was told 5 minutes. Okay, that's a 5-minute stone. Let's do it. Let me see where I am. All right, I'm out of the way here. Just a sec. We fell out here. I'll just go back in. That's it. There we go. Okay, just a sec. I have to rejig my scope. I got too many loops in it. Let's see here. Okay. Just a sec. Okay, now we're back. Go forward. So when you usually the small wheel is locked to the right in the duodenum. You want to lock the small wheel to the left going through the pylorus. So we have to change the small wheel when we're going to re-intubate. We go down. Okay, now the big wheel is down. This is this crazy duodenum. It's a short duodenum. We'll see if we can get down here. We'll go further. And we're just going to pull right. It's a short. Let's see if we can lock in here. It fell out again. Just a sec. So again, small wheel back to the left, back through the duodenal cap. There we go. Now it's high up on the second part of the duodenum, this papilla. Don't ask me why. Okay, now, so we're going to try to get. Here's our bigger basket. This is the lithotripsy basket. So now we're in position. Let's fluoroscopy. So now we're just alongside. So the best thing to trap any stone is to open the basket above the stone. So we go up here, we open the basket here, all the way. And now I'm controlling, that's fine, just leave it. I control the basket. So where will the basket get trapped in the basket? At the point of maximum diameter of the basket, which is 1/3 from the tip to the bottom of the basket. That's where it opens up. So we're going to just try to see if we get any of that stone. I wanted to see if I can get that basket open to a maximum. We need 2 wires to get around it. And I don't feel I've trapped it because if I pull back, I'm getting some resistance, but I'm not. I want to be able to move the stone back and forth in the basket. Now, I'm not sure if I have anything here. I sort of think I don't. But I'm going to just change. I shorten my scope now to change the basket orientation. And then what we will do is we will close the plastic. This is not with the metal. And see if anything is trapped. We're not doing lithotripsy here. We're just closing a basket. And what do we have? We don't have it really. We have something. We'll stop here. We can pull this out. Whatever it is, it's a small little bit of nothing. Okay, so we open up. Get rid of that. Okay, that's fine. We'll close the basket again. And now we'll go back up. Now,
dependently on the outcome, would you consider finishing the procedure with the stent in?
Yes.
Okay.
Yeah, I agree. So now, the other way, if the basket doesn't trap, try to go up the other side of the stone. Usually, if you can get the basket to go to the, I'll show you this side. Now let's see, go up the duct. Hold on. There we go. So we want the basket to go up this side of the stone. Sometimes it's a little bit, it's not going sliding up along that wall. It's a little different. Now we may flip the basket up open. It'll flip above the stone. So we open the basket. Open, open, open. Let's see if it's going to do it. Yeah, and now we're below. So close the basket. Not going to do it. Okay, we'll try to get above the stone again. No, it won't do it here. I don't think there's enough room for us to get up that side. I'll go up. Oops, I'm losing my duodenal position. There we go. You see the basket. I want to go up. Let's try if I get up here. Okay, we'll try something. It's just, I'm going to try to push up a bit. We may have to reshape the basket. Let's open the basket. This is not going to work, I don't think.
Okay, Professor Haber,
yes.
we are going to go back to Puma.
you.
Okay.
Good to see you.
You're welcome.
Bye.
Bye. Sometimes it will come back. There. Okay, that's good. Okay, and open the basket all the way. And we'll see. Sometimes it'll open some there. So now we'll see if we can catch anything else. We don't have contrast, but let's close the basket slowly. Close the basket, close, just pull it closed, yeah. No, we don't have much, so that's okay. So we'll take a regular basket. Let's just see what we have, anything. Just the Tetra catch, yeah, we have fragments. Okay, so now it's okay. We'll clean this out. We'll go with a regular basket.
Would you consider the balloon or the basket normally?
For now,
For
basket,
now.
because
Okay.
we may have to,
Bigger fragments.
we could do outside the scope Sohindra lithotripsy
Okay, perfect.
if we catch it.
Yes.
This is an Olympus Tetra catch, I hope.
Yeah.
Yeah, it's good. I like this. Okay, we can flush with contrast.
Dacă prinde ceva, vrea să bage litotriptorul sau Hendra de salvare și să-l...
Okay. There we go. That's good, thanks. Now, let's just...
Îți pare că îi se pare ceva ok să fac chestia asta. Na.
No,
That's
we
just
just
push my
open
goal
a
out.
little halfway. That's enough. Inject. I don't want to go too high. I want to get the fragments that are low down first. So I'm not going high. We stay low. We have a fragment just to see what we get here, just with half a basket. So it's only half open. It's okay. We'll see what we have just with this. We maybe don't have much. Just a little not close. So we'll go back and repeat this a few times to clean out.
But maybe you crashed it.
Yeah, no, I think the stone
Yes,
is
the
crushed.
stone is crushed.
I'm just removing fragments now.
Okay.
So it's, you know. Okay, yeah, look,
Okay,
if you look
it's
at
clear,
the
it's
image,
clear.
we'll save. There, it's really, maybe up on the left side there's a big piece. So we may go back with mechanical after we clean out what we have. Okay, so now we open the basket all the way. Okay, don't try to get this. Okay, it's okay.
Da.
We'll probably need another basket before we finish. Close. Okay. Maybe a balloon will be more efficient at this point. We might want the balloon again. Let's just take one more and see what we get here. We get the
Okay.
yeah, the fragments there. Okay, open. Just a sec. Okay, open. Contrast. Okay, contrast. So it's good. I think it shows. Yeah, because
of
we can show the audience. We'll save that image. Oops, not a good one. We'll do it again. That's a better one. Okay. And now we'll come down.
Would it help to go upwards and flush with saline?
Yeah, but I think it's too tight here because it's
okay.
even this. It's hard to come out, even though we did a big there. I pull, but it'll break easily. Yeah, we could. I think it's all valid. Everything's valid. With big stones, we probably do everything together. Eventually, we do it all.
Yeah.
Okay. Yeah, save that image. Yeah.
Oh, great.
Yeah.
Great.
Yeah, open.
I'm sorry that they couldn't see this live, but it's great.
No, but we save the images.
Yes, I know.
So you can take the images at the next session, just show the the sequence.
We'll show them.
Show the sequence. It's good so they can see it works. Okay.
Okay.
Now we have to see if we get this through. No, so now it's soft. I have to pull hard. There. But, you know, we may have to get another basket. We may ruin this basket. We'll see. Oh, open. That's still okay. Close. Not perfect, but maybe okay. Okay, let me just get the rest. You get another basket handy, yeah. Close, 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 sorry.
Wouldn't you find it abnormal to be such a disproportion between the left and the right hepatic ducts?
Yes, yeah, this is a, she has underlying duct disease.
Because
I'm convinced.
in cholangioscopy, the hilum looked normal.
Yeah, okay, contrast, yeah. We have to reset the timer, yeah, okay. Contrast, yep, inject. Okay, hold it there. Stop. Now I have to pull hard. There, okay, breaks through, it's okay.
Maybe you crush it more.
No,
so
it's crushing, yeah.
yeah.
Once you have the first crush,
Yeah.
then you can crush the fragments. And they get stuck there because we pull against the papilla.
Yeah.
But gradually the papilla dilates more. But it's a safer way to do it. Okay. And we would give all of our patients Indicid.
Okay.
Everybody, 100
Yeah.
milligrams. Okay, open. Okay,
Yeah,
contrast.
even if you didn't perform sphincterotomy.
Oh yeah.
Okay.
Because big stones with mechanical,
Traction, yes.
higher
Okay,
risk
okay,
of
I see.
pancreatitis. Okay. Okay, stop.
Da, chiar dacă nu au făcut sphincterotomia. Fiecare când tragi prin
okay.
papil. Da, e just. E just.
Okay, let's take the balloon now. So we have to go up the left and clean out the left side.
Would you do prophylactic antibiotics in this patient?
Yeah, I think so. Yeah, yeah. But also, if they're in a hurry, we can put a double pigtailed stent, and they can
Okay.
finish this later if
Yeah.
they want the room empty. We have to ask
We'll
them.
ask, yeah. Ce anume? Îi dăm voie de sală să se gândă.
Because we have to come back anyways. Big duck, we always come back.
Yeah, yeah, yeah.
She needs a follow-up anyway. Okay. Advance the wire. Okay. Oh, yep. Yeah, yeah. Stop. 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 No, no, no.
Da un dublu pigtail, vrea de 10 French probabil, da. Dublu pigtail 10 French, nu știu cât de lung aveți, dar nu contează.
Okay, wire back. No, not going to work. Okay,
10 French double pigtail?
No, 7. So,
7?
just to prevent impaction.
Okay.
Okay, advance the wire.
7 French dacă nu, 7 French double pigtail.
No, plug it back. Push the wire up now. Stop. There, okay, good, go more.
It's good.
Yeah, it's good. Okay, stop, okay. Yeah, loop is good, stay the loop. Okay, I'm gonna follow. It's okay, the loop is okay, I don't mind.
7, da. 7 vrea. Cred că 7 cu 7. Așa vrea, 7 French double pigtail.
That's good.
So, 7 French, 7 centimeters, okay?
Yeah, it's fine, yeah.
Okay,
Okay,
perfect.
blow up the balloon to 12. Okay. Okay, blow the balloon to 15. Okay, stop. Let's see this. Contrast.
Las că văd, da. Uite.
Good, that's a good one. Okay, stop. Keep the wire up. Okay, let the balloon go down to 12.
Da, de asta zicea și el, că noi... Da, și în dreapta e, na, cât de cât, 12, mai puțin oricum. Eu l-am întrebat dacă îi se pare normal să dilate mai mult pe stânga decât pe dreapta. Deci că nu. Nu. Și așa mai mulți spun că evident trebuie să faci vizibil partea stângă.
No.
Dar noi, da, da.
Keep the wire up. I can let the 1 cc out of the balloon now. Okay, stop. That's coming a lot of junk here. Dirty bottom. Okay.
Dar au făcut frumos, au văzut frumos pe...
One more cc out.
Da.
Okay, one more cc out. One more cc out. Yeah. Yeah. One more cc out. Okay. Okay, there's some debris there. I have to go with
Maybe
the stone. Okay.
stone, yeah.
Yeah, debris. We pulled it down, but didn't pull it out. Okay, because it's eccentric. Okay, so now I think that's enough for one day. We leave the wire. We put the stent in.
Yeah.
Okay, because you have to go back, and I think they have to
Stent on.
change the room. Okay. Keep going. Okay, so then let's go back up with the balloon. And then after this, the basket again, and then we go back with the balloon. We go back and forth. Gonna go up. Okay, okay, pull back on the wire, back a little bit. Back on the wire, back, 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 back. Okay, go to 12. Good. Okay, contrast please. Now we try to put in 20, 30 cc's. We try to flush down.
Okay.
We have to keep flushing. Yeah, that's coming out a bit. Advance the wire now. You did it already. Good, thank you. Okay. Yeah, I think it looks good so far. But we're still leaving a stent because you don't see everything. In a big duct, you can miss small stones. We still have stuff here at the bottom. Let 2 cc's out of the balloon. Okay, hold it there.
Yeah.
One more cc out.
So it's really narrow down there.
Yeah, but the balloon is very big. There. Okay, now let's go with the basket, balloon down. And then after the basket, yeah, basket, but then after we go back with this to put the wire in for the stent. Yeah, basket. Yeah, it doesn't matter, any basket. Yeah. Right. Okay. It's going to come out, I think. As well, when you use the balloon, you get the stones impacted at the bottom. So you have to loosen it up. Okay. Okay, open the basket. Contrast. No, go ahead. Everything. Now, it's coming now. There. Let's use the contrast to push the stone out now. I suck the duodenum while he's pushing the contrast. Okay, that's good. Everything should be, then when all the stuff is at the bottom, we pull the basket down to grab it. At this point, it should be down, we'll come down. And now we should have it. Yeah, we have more, lots more. I think we have more, quite a bit. It's okay, it's coming. There, stop, don't pull it, don't open it up, okay. Close, yeah, okay. We'll do that again. Hard to see now, so much.
It was a good passage with bigger tank.
Yes. Because the balloon goes around the debris. Okay, now. There's lots of debris. Okay, good. Okay, now open, yep, and contrast. Contrast. Okay. Let's see, it comes out. Contrast, yeah. Yeah, now it's going. It's good. It's great. Good work, yeah. Okay, perfect. Yeah, good. Yeah. And now he's sending it over. Okay, good. Yeah, one more. Yeah, now it's, see, now you can see it's coming down. There. Okay, we stop, and now we try to open up all the way. And now it's getting a lot more here. There, you see, it comes out. Close. Have to loosen everything up here. Okay, now. Oh, just wait. Just a second. Okay, now open. Inject. I don't know, there's a low cystic duct takeoff. There's something underneath. Maybe cystic duct. You see this? Okay, now we come down. Open all the way, yeah. Okay, good. That's okay, yeah. That's okay. Okay, close. I think we have just the smaller pieces now. Yeah, another piece. It's just getting it down. It's not so it can come through. And so we try to, let's see, open this up now. Open. Contrast, the whole thing, more contrast. Okay, hold that. I'll have to try to get this thing out. It's a fragment. Okay. Okay, hold that. Open all the way.
It's open all the way.
Okay. Close all the way. Yeah, I know it. That's the way. We have pieces. It's true. There's one here. I want to loosen up here. Okay, open all the way.
So nice, but they are stopping.
Yeah, that's now it's coming out this one.
So we need to put the stand and
We need to insert the stand because they need the
Okay, we just get this last piece out.
maybe.
Okay, let's put the wire. Yeah, mostly we have. Thank you.
Da, ce că face și până cu balonul că intrăm în da, și fiind drept, poți orienta așa mai moale.
Adică îți trebuie imagini la fiecare poș de asta, știi? Măcar imagini. Ori ce mai intră așa aici, la tot doză, într-adevăr, așa lucrează fiecare zi.
Nu, de sus plecat au făcut o strictură.
Advance the wire. Yeah, yeah, good, good. Yeah, one a little more. Perfect. Okay. Good. Okay, now we come out, wire in. There. Yeah. Stent, 2 more minutes. Finish. Huh? Yeah. You have a black mark I can put on here, a pen, marker. Grazie.
Da? 7 mm. Stai așa. Da, și când am fost de la punte și când am fost de la punte, tot așa, la sistemul de rec, tot așa, sunt 5 metri, uneori de până gândă și... Da, era, aici era, știi? Da, cred. A, era, ok, da, așa, screening, știi? A, unde e mică, am început și să fac șamponezul, dar nu cheamă. E eliminat, cred că. O să o ridicați.
Okay, wire back. Coming up. Yeah, there. It's there. I go. Come back. Hold it. Wire. Pull the wire back. Oh, it's up high. Okay. Wire out completely. Nice. Okay, that's good. Okay. Great. Yeah. Thank you.
Of course.
Thank you. Thank you. Yeah. Okay, thanks. Ah, good. Nice.
Yeah.
Well, good.
But I don't understand why don't you use the laser in the case?
They don't have one.
I have here, come on.
They told me this morning it's not working.
It's working.
He told me it was not working.
Come on. I have it here. It's working, it's perfect, it's
Laser or electrohydraulic?
laser.
Yeah, we could use it.
It's 50 watts laser.
They told me it wasn't working, right?
Okay.
Otherwise, yeah, we need laser.
No, you don't like laser because
They told me they don't have it.
we have it here.
No, George told me they didn't was not working. I love laser. Now you tell me. They said they tried it and they couldn't get it to work. They don't have the probe, or they don't have. There's something. They have the machine, but it's not working.
Okay.
That's what they said.
But you
Yeah.
like it.
I use electrohydraulic. No, electrohydraulic is better.